Very nice slide here. Due to this ventilation strategy, the wash of CO2 wouldn't be the best, and it's expected that CO2 would be high and pH would be low, but it's all accepted until the pH is 7.2. What if the pH kept going below 7.2? That time, I have to do something. So usually, I need to wash the CO2 to improve this pH. This means I need to put additional air inside the lung. So first, look at the plateau pressure to answer the question. If the plateau pressure below 30, that means the alveoli can accept more air inside to wash the CO2 and improve the pH. By that time, just increase the minute ventilation by increasing either respiratory rate or tidal volume, whatever. Push more air inside as long as the plateau pressure below 30. I am away from the barotrauma risk. The situation is going to be more difficult if the pH is below 7.2 and plateau pressure is above 30 centimeter water. That means you don't have any room to add any air, additional air inside the lungs. So what can I do now to correct the CO2? Now stop and think. Stop and think. Do I need urgent control for BaCO2 for that patient? Sometimes we have neurological condition with the acute severe asthma. So the CO2, higher CO2 would be deleterious for this patient. I need to correct it. For example, if I intubated the life-threatening asthma patient and there was respiratory arrest for some time or cardiac arrest for some time, so I'm expecting that there would be some cerebral anoxia injury. So this patient's ICP might be high. So we need to fully correct the PaCO2. But I can't do that through the ventilator because the plateau pressure is above 30. So the only way here is extracorporeal CO2 removal, ECMO. This is simply ECMO for CO2 removing only. Or to buffer the acidic CO2 by NaHCO3, which is debatable practice actually. If the patient neurology is fine, so there is no reason to or urgently control or normalize the CO2 completely. So just do nothing and consider it as permissive hypercapnia. Very nice slide. Now I have the patient deeply sedated, paralyzed on the mechanical ventilation on beep 0 and giving bronchodilator therapy. So what's next? How can I go further with the patient? First step, if all targets mentioned fulfilled, plateau pressure is below 30, O2 beep below 10, wheezes are better, saturation is okay, EBG are nice, so let's wean sedation. Neuromuscular blockers first, then sedation. This is the first step. As possible. And then, with return of some spontaneous ventilation, by that time, we need to apply beep. So, in the beginning, we applied beep 0 because the patient is deeply sedated, paralyzed, and all the presses are controlled breaths by the ventilator, positive pressures. So, there is no point to add beep here. But now, the patient is spontaneously breathing for some preface. To help the patient to overcome the intrinsic beep inside, we need to apply beep. What is the idea behind that? Let's consider that the patient has intrinsic beep like 10 centimeter water inside, trapped inside the alveoli. If the patient is starting spontaneous breathe, he needs to initiate negative 11 at least to overcome this 10 inside, which is too much effort. So it's like here, this is the O2 beep inside, and this is the baseline. If the patient starts from 0, he needs to do all this effort to like minus 11 to overcome this positive 10 inside. What we are doing now by the sit beep like 8, so the patient will start the breathing from here. So we keep the patient quite closer to the O2 beep level. So now if the beep is 8 and the O2 beep is 10, all the patients need to do is just do -3, which is now quite easier for the spontaneous breaths. So here, we applied the beep of 8. Now, the patient is very close to overcome 10 by doing just -3 centimeter water of negative pressure. So the beep of 80% of intrinsic beep has a rule in spontaneously breathing patients only. And of course, we need to adjust trigger sensitivities. Check your ventilator flow trigger and make it easier for the patient to decrease the work of breathing. So at some point, we need to apply PEEP if the patient started to take some spontaneous breaths to help him to get or overcome his own O2 beep inside. So this is, without beep, he will start the breathing from the 0 point, and he needs to do all this effort to overcome the O2 beep by was setting some beep like 8. All the patients need to move like -3 to overcome the O2 beep and they take the breath nicely with low work of breathing, which is essential to guard against exhaustion. Then we'll follow the usual protocols of slow weaning and extubation. In the life-threatening asthma on the mechanical ventilator, we have some specific treatments, like the one mentioned before, Sabaneps, Samaneps, steroids, magnesium, and for the mechanical ventilator patient, we can add more treatments like IV bronchodilators. 2 examples, IV salbutamol, in addition to the salbutamol nips. This is the dose, and the most famous side effect is lactic acidosis. Very, very common side effects, which can happen after 4 hours of starting the IV salbutamol. So keep following the lactate level on serial EBG on any patient on IV salbutamol. If this happened, you would have to just stop the salbutamol IV. The second medication, IV aminophylline. Loading dose, maintenance dose, that's fine. But we need to know very well that this medication therapeutic index is very low and very likely to be toxic. Side effects, arrhythmia, vomiting, convulsions. So aminophylline plasma level should be kept between 10 and 20 mic per ml. Very important, because the therapeutic index and the safety margin of this medication is very narrow. So keep the level of the medication between 10 and 20 mic per ml. What else we can do for this complicated patient? Inhalation anesthetic agents like isoflurane or sevoflurane. Very powerful bronchodilators, but they can induce severe hypotension and very difficult to be applied in ICU setting. This is a problem. But both of them are very effective in relieving the resistant acute severe asthma or life-threatening asthma and correcting the intrinsic beep inside the patient. Now some quick questions answers. What about the antibiotics? Should I prescribe antibiotics for routinely for all patients with life-threatening asthma? The answer is no. Most of asthma attacks are precipitated by viral infection, not bacterial infections. That's why antibiotics shouldn't be prescribed routinely unless there is evidence of bacterial infection, like high procalcitonin level. Otherwise, don't prescribe antibiotics. Second question, leukotriene antagonist like montelukast. This is preventive or prophylactic medication for the chronic controlled asthma patient. But in acute severe or life-threatening asthma in ICU, it has no role in treating the condition at all. It prevents the condition, but doesn't treat the condition. The same for monoclonal anti-IgE antibodies like omalizumab. Again, it is preventive, prophylactic measure, but is not a treatment for life-threatening episodes. Very famous question. Non-invasive ventilation, does it have a role in acute severe asthma? The answer is no, at all. There is no role for NIV in management of life-threatening asthma. Once you think about intubation, proceed and intubate, ventilate the patient. NIV, the strange thing is NIV has a great role in COPD patients who are have some airway disease as well. But NIV is not effective at all in managing acute severe asthma. And honestly, I don't know why. But studies prove that NIV has very limited role in managing life-threatening asthma. Thank you.